Okay, so we are on time to start now. Sorry for the confusion about the timing that is on the slide. So this is the OCTA course, how to understand what we see. So you will have those topics and speakers, Giovanni Storenghi, Joao Figueira, Nicole Etter, Marie-Bénédicte Rougier, and myself at the end. And we will cover all different phases of the OCTA images that we get, the machines, and how to understand. And first, Giovanni Storenghi from Milan, please give us an overview on OCTA. Please, Giovanni.
Thank you. Yeah, it's over here. Thanks. So more and more efficient during, the meeting. Thanks. So, thank you, Jean-François, for again organizing this meeting and this course, and I will give you an overview of OCTA. These are my disclosure, and probably the most important is not written here, but I'm a multimodal imaging supporter. So I'm always saying, because it can be biased, my presentation on just the OCTA. So when we speak about fluorescein angiography and ICG angiography, we think probably about two types of, the ones done with the scanning laser ophthalmoscope, and the other one created with a fundus flash photographer. But when we speak about OCTA angiography, this is the list of the possibility. So there are different algorithms that can create different images. And of course, 5 OCTA methods, 2 averaging methods. And if you put all together, you can get a different image from the same eye. So for example, here, using the same machine, but 2 different software, the old software by Heidelberg and the new one, you see that the images looks a little bit different. The same for if you take the same software, but 2 different images, 2 different instruments, like the Plex Elite Swab Source and the Cirrus spectral domain, you get a different images. Then remember all the time that the images are taken, are created by a B-scan. So it's always important to see the B-scan to analyze if there is an artifact or not. So here, some example of the instruments. Probably if we add some Chinese, instrument, we can actually have other 3 lines of instrument. But at least the big difference is that the swab source, that are the ones that you see with the pink background, and the other are a spectral domain. How to improve the image quality? First of all, the projection artifact removal. There are many software, many algorithms that can actually create. This is just to see the vessel, retinal vessel projected during the slab that you try to measure on taking on the neovascularization. And here, when you apply the removal software, of course, you can miss something, some signal of the neovascularization. Also, you can actually improve with averaging images. You take a single OCTA, you repeat it 2 or 3 times or 4 times, and then you average and you get a better image. But there is also now the possibility with AI, some instrument that you do from a single OCT image, you can actually get a more sharp image because it's AI is working on that. Very different also for different segmentation layers. This cartoon allows you to understand how it works. Now, the problem is that each one is taken a different way. So if these are the same eye with different instruments, and I just want to underline these 2 vessels that are barely seen in the superficial layer, but when you move to the deep layer, is exactly the opposite. So identifying superficial or deep can be, depending on the instrument that you use. When you move to the deep layer, is exactly the opposite. So identifying superficial or deep can be, depending on the instrument that you use. The other important thing is a different space between B scan. Here, the series of all the instruments, or most of the instruments that are available in the market, and you see that between one B scan and another, there are, we move from 5.7 microns to 12, 13 microns. Why this is important? These are the same patient taken with the two different instruments taken the same day. And if you look at the vessel, the size of the vessel is completely different. And of course, also, the space between vessels is different. Now, why this happened? You remember that this unfast B scan is obtained by, unfast image is obtained by different B scans. And the distance between one B scan and another is filled by the computer. So if you have a lesion, B scan closer one each other, of course the vessel can appear smaller than not when you have a more space. And here, in fact, you see that the size is depending on the difference between, the space between one B scan and the other. Why this is important? Well, when you measure, for example, if you look at a different instrument and you look at the vessel density or the fractal dimension or the foveal vascular zone, the numbers can be completely different. So if you follow a patient, please remember, use the same instrument. Otherwise, you will mix up all the data. And of course, it's not only that, because everything can change depending if you are in focus or if you change the different type of algorithms. Now, what about the artifacts? I remember that when we started to use the OCTA, the big problem was the artifact. Now, I think the most important is still the projection artifact. What it means? It means that if you have a vessel, it's projecting on the deep layer. The problem is that, why is not projecting there? It's the famous avascular area. Well, we have to go back to the OCTs. And you probably remember that the OCT, if you look at the OCTs, the end fiber layer are only visible if you tilt the B scan in the way that, the lights, it's more perpendicular to the fibers that are oblique. So because of that, you will never see anything except there is a vessel or except that area became more reflectant. And that is the reason why. And you see, for example, in this case that it's a courtesy of Catherine Hagen, you see here, it looks like a very nice new vessels. But in fact, if you look at B scan, so remember, look always at B scan, there is an increase of reflectivity in the avascular area. And because of that, you actually see here, these are not new vessels, but just the retinal vessel that are projected there. So, only final suggestion. Please always double check the flow in the B scan, as I showed at the beginning. Always double check the B scan for changing in reflectivity, and always move the slab up and down. Why that? Because if, for example, you follow a patient with a neovascularization and you have fluid, you have the lesion is very nice, but you treat with anti-VEGF, and of course, the first thing that it happens, the fluid is going away. And so the lesion can move down, and moving down, of course, if you take the slab in the same position, say, wow, the lesion disappeared. In reality, it never disappeared. It just moved down. So please remember, don't stay using the conventional certification, slabs, but just move up and down with your mouse. Thank you.
Thank you very much, Giovanni. Always wonderful images and a lot of logic to understand trying to understand what we see. I have a question for you for wet AMD. We'll discuss wet AMD with Nicole, but how often do you do the OCTA for wet AMD cases? Baseline, each visit, never?
Baseline.
Baseline.
And that it's important to me, particularly when there are the double layer sign and it's not clear if there is just a fluid or it's really a neovascularization. So that is the time that I use. But if you want to differentiate, for example, lesion, I think OCTA is not the best instrument to do because if you have, for example, a type 3 neovascularization, it's not easy to detect. If you have a polypoidal lesion, the polyps sometimes are not visible. So I think it's important at the beginning. And the other thing is that it doesn't give you the information about the activity of the lesion. And B-scan is much better.
And just to make the transition with the next for DME patients, often, as you mentioned, there are many artifacts. The automatic segmentation is confused by the edema, the loss of contrast between the lines. And so then, do you think it is relevant to do the OCT at baseline, or you wait to do it, you wait for the retina to be dry?
In diabetic retinopathy?
In diabetic, yes.
Yeah, I think it's OCTA would be useful to identify because the eye contrast, the ischemic area or not perfused area. I like to better to call not perfused because remember that the OCT is showing not the anatomy, but if in that moment the flow is sufficient to be detected.
Yeah. That's very important. I mean, if there's one thing you have to remember, it's what Giovanni said. The image is not it's not the reality. It's the image of the reality, and you rely on the computer, all what is in the machine to create that image. So you have to be very, very careful. That was amazing, your case where the vessel appears or disappears depending on the machine.
Where you have exactly.
Yeah, and the segmentation. That's fantastic. Okay, Giovanni, thank you so much.
Thank you.
Okay, so we move on now to more specific diseases, and for diabetic retinopathy, João Figueira from Portugal. Please, João.
Thank you for the invitation and to present the OCTA. Talk about OCTA in diabetic retinopathy. As present, this is my financial disclosure, none of them related with this topic. As mentioned before, OCTA is a revolutionary technology that can give us a high-resolution idea and analysis of vascular network of the retina. And as diabetic retinopathy is strongly linked with the microvascular alteration, it puts this tool, this technique, very useful, at least theoretically, for clinic and research. These are the topics that I will go through this presentation. As presented before, for the first time in vivo, it was possible to show a superficial and a deep retinal plexus in the retina. And of course, it has been proved that both of them are changed and altered by the diabetic retinopathy progression. It's not clear what is the most important of them and what's the earlier one that has been altered at the initial phases and the later stage. But this is related probably with the stage of the disease that we are looking and analyzing, and also with the machines that we are using to check it. One important advantage of this technique, the OCTA can give us vascular quantitative parameters that are automatically measured by the equipments that are commercially available, and the parameters that we are normally used in the clinic and be referenced in the literature are vessel density, skeletonized vessel density, perfusion density, and non-perfusion areas. And also the foveal avascular zone, mainly measuring the area, the perimeter, and the circularity index of the fans, other less used are listed in this slide, but as I said, they are not so used in the clinic and the research and the literature at the moment. What makes these metrics useful in the diabetic retinopathy? Because they change with the progression of the disease. And these metrics can differentiate diabetic, including diabetes without retinopathy, with healthy eyes control, and differentiated eyes with the disease in different levels. And the reduction of these vascular metrics are important at different stages. For instance, in the more initial stages, the skeletonized vessel density seems to be a robust metric to evaluate those patients, especially in the superficial capillary plexus. And regarding the foveal avascular zone, the perimeter and circularity seems to be more important than the area. Non-perfusion areas, capillary areas, seems to be important at the initial stage, but also in more advanced stages of the disease. And at this point, in the more severe cases of diabetic retinopathy, also vessels perfusion and perfusion density seems to be also a good metrics to follow them. You can see in the image on the right a progression of the disease and also progression in vascular metrics and OCT image damage. Show that the initial stage of the disease are more focused in the perifoveal area, and using the swept source OCT with wide field image, we showed that in more severe cases of moderate to severe non-proliferative diabetic retinopathy eyes, these changes are mostly located in the mid-periphery of the retina. And curiously, another paper from another group using wide field image showed that the metrics of OCT can be used for staging diabetic retinopathy. And the isolated metric that was most robust to distinguish the different phases of the disease was capillary non-perfusion areas. And the combination of the metrics, especially in the superficial and deep capillary plexus data, can increase inclusively the discrimination power for staging diabetic retinopathy. And I will say that at this moment it's pertinent to ask if a single OCT exam could substitute laborious and time-consuming ETDRS grading. It will be very useful in the future if we can do that. Regarding the OCT and the ability to detect microvascular alteration, one of the earliest alterations are the microaneurysm, and the OCT can detect them in the more deep capillary plexus, especially using the color map OCT image, but unfortunately is less sensitive than the conventional angiography. As you can see, in the red circles that we can identify a microaneurysm in fluorescein angiography, we cannot see them in the OCTA image. Also, OCTA can detect microvascular alteration like IRMAs. This are represented in the interrupted green circles in this image. You can see the microvascular alteration with flow in the inner layers of the retina connected with superficial vascular plexus, and we can distinguish from the normal neovascularization. Neovascularization can be also well detected and characterized in the periphery and also in the optic nerve. And compared with fluorescein angiography, it has an advantage because fluorescein angiography can identify well the neovascularization, but due to the rapid and strong leakage of these lesions, the dye obscures completely the neovascularization, and the neovascularization networks and dimensions can be easier detected in the OCTA image. Our group performed a comparison and a correlation between OCTA metrics and neurodegeneration progression. In a 3-year prospective study, we found that the neurodegeneration progression was associated with a decrease in capillary perfusion. So we could conclude that diabetic retinal neuropathy is probably linked with microvascular changes. And one main issue and limitation has been already talked in the previous presentation. That's the limitation to use this technology with diabetic macular edema. As you know, OCTA makes automatic segmentation of the layers, but if you have a structural alteration like in diabetic macular edema, you can have errors like in this case on the right. That the segmentation was wrong, and the OCTA image and exam will be completely unuseful. If possible, we can manually change and correct the segmentation, but sometimes it's very difficult and time-consuming. I think the last slide? It's closed. I think time out. This is last slide, only to put on the front to see and compare the pros and cons of the advantages and limitation of using OCTA in diabetic retinopathy. I think it's all talked, and it's important to retain in your retina. And I will pick the pros here, the resolution of retinal vascularization and the automatic quantification of the metrics in a non-invasive exam, and the counts, it's the limitation of the leakage that's missing. We don't talk too much, the absence of leakage information that's obtained in the conventional angiogram. And finally, and important, it's the lack of standardization. Professor Giovanni talked about this because the different equipments have different measures and metrics, and we cannot compare them. Even the nomenclature that's used in the OCTA papers, it's different from one to the others. And if we don't have an uniformization, we cannot join the information, the data, and cannot compare patients from one center to the other, neither from a machine to the other. So it is important, otherwise it's not useful. Thank you.
Thank you very much. Thank you very much, with very nice images. I have just one question about the wide field, because obviously diabetic retinopathy expands beyond the 3x3 or the 6x6 usual square that we do. So, but to have wide field images, you need to do a montage, or you need more time at the acquisition. And some machines are doing 8x8, 11x11 now, maybe more. But how often do you do wide field as compared to, let's say, the 6x6 in diabetic retinopathy cases? Do you think it's necessary, or it's just on demand, or?
This is a very good question. The first limitation is the cost of the equipment. This is a very different equipment, swept source. I use the Plexilit, and Plexilit don't gives you metrics, so it's in absence, but gives you the wide field that's important.
And the Canon is even wider.
Yes, it's true. I don't have experience with Canon. With the Zeiss machine, you must have the montage of pictures. It's impossible to do it in a routine-based clinic, and I do it when I do research and when I have specific cases when I need to see the periphery ischemia and neovascularization, because it's very useful. You don't need angiograms, conventional angiography to see very clear the ischemia and the neovascularization. So it's when I choose to do it.
Otherwise, you stay to the 6 by 6. 6 by 6.
6 by 6.
Okay. Well, thank you very much, João. Thank you again. So now we move to the AMD, not neovascular AMD, but AMD with Nicole Etter from Germany.
Thank you, Jean-François, for the invitation. I have no financial disclosure relevant to this presentation. So the term white dot syndromes includes heterogeneous pathologies due to chorioretinal inflammation, even if the pathophysiology of these diseases is different from one syndrome to another. And up until these last years, the diagnosis of white dot syndromes was based on fundus or retinophotography and autofluorescence, OCT B-scan and OCT en face, and of course, fluorescein and ICG angiography. But now we have OCT angiography, which allows choriocapillary and choroidal visualization. And already previous papers have described the OCT-A characteristics of white dot syndromes from case series based on comparison of OCT-A versus ICG angiography. So the question is, could ICG be substituted by OCT-A for the diagnosis of white dot syndromes? Many papers comparing both techniques showed that OCT-A can detect choriocapillary void, which colocalized perfectly with the hypofluorescent zones visible on ICG. And it is particularly true in placoid syndromes, uveitis with granulomas, and multifocal choroiditis. But unfortunately, the main limitation of OCT angiography is its limited size of view. Here you can recognize a typical case of AP-MPPE on the ICG angiography with the hypofluorescent areas. And thank you. And here you can see on the OCT angiography that the choroidal voids colocalize very well with the ICG images. So the purpose of my talk today is to show you how you can manage the diagnosis of white dot syndrome using OCT and OCT-A. The most important is to remember that the aspect of the OCT angiography depends on the primary site of the disease process. Indeed, if you have a disease with an inflammatory outer retinal involvement without choroidal ischemia, in this case, you will get an OCT en face positive, but the OCT angiography will be negative. But if you are facing a disease with a primary choriocapillaris or inner choroidal involvement, mainly ischemia, in this case, both OCT en face and OCT angiography will be positive. So let's see some examples, and let's start with mutes. So you can see and recognize a typical case of mutes on the fundus photography with the little yellowish spots spreads on the retina, the hyperautofluorescence, and on the B-scan OCT, you can see the protrusion of hyperreflective material on the outer nuclear layer associated with some ellipsoid zone interruption. And if you perform an OCT en face, and if you make the segmentation at the level of the ellipsoid zone, you can see some hyporeflective spots. But if you perform the segmentation at the level of the outer nuclear layer, in this case, you can see hyperreflective spots. But if you perform an OCT angiography, you can see nothing. The OCT angiography is still normal because in mutes, it's a primary photoreceptor involvement and not a choroidal involvement. Let's go to placoid syndromes, and you can recognize here a typical case of APMPPE. And on the B scan, you can see the hyperreflective material at the level of the outer nuclear layer. And if you perform an OCT en face, you can see at the level of the outer nuclear layer, you can see a beautiful hyperreflective lesion. And if you perform the OCT angiography, you can see the black zones which corresponds to choroidal ischemia, and they colocalize very well with the fundus lesions. Let's go now with multifocal choroiditis and punctuate henochoroiditis, which are two different presentations of the same disease. And here, this is a typical case of what we are used to call multifocal choroiditis. And you can see on the photo that there are numerous lesions, and some of them are already old and scarred, and others are new. And if you perform a B scan through a new lesion, you can see these typical conical hyperreflective lesions, which extend from the choroid to the subretinal space. And sometimes, like here, you can also see that there is a choroidal thickening. Now, it's a case of punctuate henochoroiditis. And if you look at the fundus, obviously there is a huge yellow lesion on the macular area with a subtle hemorrhage. But you can also see above this huge lesion that there are some very small yellowish spots. And if you perform a B scan through this very small lesion, you can recognize this typical conical lesion. And if you perform a B scan through the macula, you see that there is a hyperreflective material at the level of the subretinal space associated with exudation. And it's highly evocative of neovascular complication. But if you perform also an EDI B scan, you can also see that there is a choroidal thickening, which means in this case that you have probably an acute choroiditis already complicated with neovascularization with inflammatory new vessels. But if you perform an OCT angiography, you can see on a single image both lesions. On the red arrows, you can see these little choroidal voids, which corresponds to choroiditis lesion. And you can see on the green arrows the neovascular network. Another example, very similar to the previous one. And if you perform a B scan through the macula, you can see that there is an hyperreflective material associated with an exudation. But in this case, there is no choroidal thickening, which means that there is probably a neovascularization on a scarred and old lesion of choroiditis. And if you perform a B scan through above, you can see that there are numerous lesions at different stages of choroiditis. And again, if you perform an OCT angiography, you can see on a single image both lesions, all the choroiditis lesions, and the beautiful neovascular network. So in conclusion, I think that wide-dot syndromes can be managed without an ICG angiography. But sometimes you get nothing. I mean that OCT en face and OCT angiography are both negative. So in this case, I think that there are three possibilities. The first one is maybe the outer retinal lesions are very subtle and difficult to visualize, or they have already disappeared. The second possibility is that the lesions are outside the OCT acquisition cube, And it's very frequent in nudes, and in this case, you have to go back to the regular imaging and you have to perform an ICG angiography. And the last possibility is that it's not white dot syndromes, and you have to consider another diagnosis. Thank you.
Thank you, Marie-Bénédicte. Very nice images again. And on the B scan, it really looks like CNV, in fact. And it's not CNV when you look at the OCTA. So my question is, how often do you perform FA and ICG to confront with the OCTA when you have doubts? You do the OCTA first. If you have CNV, you're done. Or you do OCTA plus FA plus ICG in all the cases?
In these cases, I think that if you combine OCT B scan and OCT angiography, it's rare that you can't see and detect the new vessels. But indeed, if you if clinically you think that there is a neovascularization, for example, because there is a subtle hemorrhage. In this case, of course, already you have to go back to ICG angiography. But it's pretty rare in clinical practice.
But if you have a small hemorrhage, then it is a CNV, and then you can treat without ICG or without FA, or you still want to do it to do everything?
To confirm, you mean?
To confirm,
no,
yeah.
If I see the new vessel on the OCT angiography, I don't need ICG angiography. Not at all. It's enough for me.
All right. Okay, thank you very much again. Do we need it? Is it a good idea or not a good idea? These are my disclosures. Okay, so we are very much used to use OCT, and it has been very well illustrated by all the speakers in many, many cases. We have the anatomy before and after the treatment by either VEGF inhibitors or steroids, depending on what you want to do. The question is how do you want to quantify? We are used to quantify the thickness when you monitor DME, for example. But do we really look at the numbers? In fact, we look at the color codes, and we see that there is less, to be very simple, we see that there is less red or more orange, and that it's getting better or that it's getting worse. But do we really look at the numbers per quarter? I don't on a regular basis. And the thing is that, as João presented, sometimes it's complex. So here you have a diabetic macular edema case. It's quite severe with an epiretinal membrane, and the OCTA is feasible when you take the full thickness of the retina, but you don't know if you don't have any artifacts related to the transmission and the detection of flow by the machine. And it's even more complicated when you have leakage. Definitely on fluorescein angiography, you see all the microaneurysms, like you showed, João, that you don't see on OCTA, but for the thickness, it's complicated. Like here, you see there is increased thickness, but the flow can be hardly detected. It's much more easier for dry retina. Like here, you have a couple of red spots, and in fact, if I go back, a couple of red spots, you see them, but you see, now that you know, you see on the temporal side that there is abnormalities here. But on the OCTA, it's much easier to see those new vessels. And if you look at the disc, finally there are also new vessels on the disc. So definitely OCTA highlight some abnormalities, as leakage in the fluorescein angiography highlights some leakage. And wide field takes time. It's time consuming. It's not easy. You need a good fixation, a patient that is going to be cooperating. But if you go wide field, you will have plenty of information about the perfusion, pre-retinal new vessels, pre-papillary new vessels. But what about quantification? So when you do PubMed and you do OCTA and quantification, you have more than 200 papers speaking about retina and glaucoma OCTA quantification. So it's complicated. The thing is that we can do it, and depending on the machine, I will present about the Zeiss because that's the machine we have in our department, but many machines now do quantification. I just want to highlight what is contributive and what you may be aware of. So using the 3x3, you can analyze the superficial plexus, and you know with OCTA, one thing that has been shown very nicely is that you can separate the layers. So with the superficial capillary plexus, you can measure the vascular density and the perfusion. What does it mean, the vascular density and the perfusion? Well, the vessel density means the vessels are skeletonized and their length is measured. So you can measure that parameter in the 1 millimeter center or in the 3 millimeter quarter by quarter or all the area, and you have numbers, and you can transform those numbers in color codes. So this is an area density map. It's nice colors. It's quite easy to understand, and you have numbers so you can quantify as you quantify the thickness. And you can do it also in the 6x6, and you have a larger area. But of course, you need to be with a patient that has a good fixation so that you are right in the center. Here you can see some of the artifacts that were shown previously. You see here on the temporal side, it looks like it's poorly perfused, but is it really poorly perfused or is it just a floater? In the color code, it's detected as low flow, but is it really low flow? It's hard to tell. And you see you have numbers here that are the center, the inner circle, the outer circle, and everything that is detected in the 6 millimeter circle. Another metric of the vessels is the perfusion, and then the perfusion is the surface of the vessels. And as Giovanni showed earlier, depending on the machine, these vessels can be detected or not detected because of the resolution of the OCT. And you have the same metrics where the surface is measured, and then you do not consider the length, but only the surface. And same, you can have the 3x3, the center, the 4 quadrants, color code, and the 6x6 with the exactly the same problem with the same area here where you have a poorly perfused image or a floater. It can be an artifact. And all this is done after the acquisition, of course, of the 6x6. And that's one of the elements that we did not discuss. It's time consuming. I mean, the fundus photography, we look at it, we are used to it. Fluorescent angiography, we are used to it. But all these analysis of the OCTA takes time using either a viewer or the machine itself if you don't have a viewer. Last but not least, about quantification, the avascular zone, and Joao presented that already. The avascular zone can be measured, and there is 3 options: the surface of the avascular zone, the perimeter of the avascular zone, and the circularity of the avascular zone. So it's 3 quantifications just for this small area. So is it something that is interesting, is useful? Let me show you a few examples. Here, it's a diabetic retinopathy. You see that there are areas of poor perfusion. The numbers are decreased. There is more blue, which means it's poor perfusion in the color code used by the machine. But you see it on your left. You already see that there are less capillaries that are detected by the machine. Another case where the avascular zone is completely expanded, let's say by poor perfusion. You also have vascular abnormalities on the temporal side. And here also you have numbers that are completely different from what I showed earlier. With the color code, it's easier. But if you look at the color code and you go back to the black and white on your left, it's very similar. So if you like the colors, it's nice, but you already have the information with the qualitative evaluation. So you can do another measurements with the perfusion and same kind of results and color. And the avascular zone, you can compare from one visit to another. And in that case, you see from examination 1 to examination 2, and there has been 3 months in between, it's exactly the same surface that is detected by the machine. Exactly. So it looks like it is extremely reproducible, but it's not always so simple. Look at that case. It's a branch vein occlusion. You have poor perfusion here in the temporal side, and that is detected by the OCTA, quantified, transformed in color code on this image on your right, and the wide field system where you have, again, the poor perfusion, and we are very familiar with those images now. But look on the top right here. You see it's blurred. It looks darker. And so for the machine, there is no vessels here. So it looks blue in the color code. But it's, we as doctors or as experts in OCTA, we recognize that the image is blurred. But for the quantification software, it's not blurred, it's missing. And so they say it's poor perfusion. Another one, same thing for the perfusion with the vessels here. You see the quality of the image is globally quite good, but in that area, it's less good, maybe because of cataract, and then the quantification is completely mistaken. So it's not always so simple, and it takes time to realize that you may be misleaded by the machine. Look here. The detection of the avascular zone is, let's say, wrong. Of course, it's much larger, but based on the gray level, the detection of the avascular zone is measured as this. So you can change that manually, but it will take a lot of time. Perfusion artifact. Look here, if you look in between those two vessels, it is obviously poorly perfused, but as there is some gray, for the quantification, it looks like it is good perfusion. So that's another mistake. And it's even more visible when you go wider. You see in that area, it looks okay, but it's not okay at all when you look at the image black and white. And in wet AMD, this is quite obvious. You have the CNV. This has been shown very nicely by Nicole. And you can have those wonderful OCT images that were very fascinating at the beginning. By the way, I like very much the B-scan of the PED to detect flow in the B-scan. That's another way to use the OCT images. But how to quantify those new vessels? Is it feasible? Is it the surface? Is it the volume? And it's very difficult because very often it depends on the position of the slab. Where do you put the slab to isolate the CNV? You see here, it's the same patient, the same day, the same acquisition, but during the analysis of the flow, the slab, you see those two dot lines, pink dot lines, I just moved them up and down, and you make appear or disappear the complex, the membrane. So once again, and that's the thing I want you to remember, it's not the reality, it's an image of the reality, and you can be a magician making things appear or disappear. Of course, the companies are working on that. They are trying to correct those parameters. They are trying to make things automatic. But I must say that since the last few years, I have been quite disappointed by what has been presented by several companies about the quantification. And I think that we have to be aware of what they are working on. We have to be aware that it's something that can be interesting, but now, I mean, at the beginning of OCTA, we were asking for metrics again and again, and we thought it was very useful. But in fact, we are using OCTA since many years now. We are using OCT since even more years, and without quantification on OCTA, it's quite nice. So as a conclusion, the metrics are available. There are many artifacts that are possible, and you have to be very careful when you look at the image. Look what slab, what is the quality of the image, etc. And at the end, do we really need and use quantification? My answer at the moment is, I think no, not on a regular basis, because there are, for example, no metrics on fluorescein angiography, and we work very nicely for the patients on fluorescein angiography. So maybe no. For research, as Joao presented, yes, but for daily basis work, I would say no. And with this, I thank you very much for your attention. And I would like to thank all the speakers, Giovanni, Nicole, Joao, and Marie-Bénédicte. Thank you so much. Have a nice day. 5 minutes behind. Thank you so much, Giovanni.